be by Dr. Mortimer Rimawi on behalf of NRG Oncology, NSABP B-52, evaluating pathologic complete response rates in patients with hormone receptor positive, HER2 positive breast cancer treated with neoadjuvant therapy of docetaxel, carboplatin, trastuzumab, and pertuzumab with or without concurrent estrogen deprivation therapy. Mo?
Thank you, Dr. Arteaga. It is my pleasure to present to you on behalf of my co-authors in NRG Oncology the results of NSABP B-52. The rationale of this study stems from preclinical and clinical evidence that showed that estrogen receptor positive, HER2 positive breast cancers are less likely than ER negative HER2 positive tumors to respond to dual anti-HER2 therapy. This may be caused, in fact, in part by the estrogen receptor acting as a pathway of resistance to escape the effects of treatment. There was evidence from some older trials done of old chemotherapy regimens combined with tamoxifen, concern about antagonistic effects of endocrine therapy and chemotherapy, but data with newer combination of more modern therapies did not exist. So we therefore hypothesized in this study that concurrent inhibition of the estrogen receptor and HER2 plus chemotherapy will not be antagonistic and will overcome resistance to treatment by improving pathologic complete responses in patients with ER positive, HER2 positive breast cancer. This is the schema for NSABP B-52. It's a randomized trial for patients with histologically confirmed ER positive, HER2 positive disease that was diagnosed by a core-needle biopsy after required blood and tissue collections and stratification for tumor size, nodal involvement, and menopausal status. Patients were randomized to one of two treatment arms, arm 1 with docetaxel, carboplatin, trastuzumab, and pertuzumab, TCHP, and arm 2 with the same chemotherapy and anti-HER2 regimen with added estrogen deprivation. Estrogen deprivation was in the form of letrozole for an aromatase inhibitor for postmenopausal women and an aromatase inhibitor plus ovarian suppression for premenopausal women. After 6 cycles of treatment, then patients proceeded to surgery and axillary staging. So the eligibility criteria briefly, invasive breast carcinoma, clinical tumor 2 centimeters or larger if the tumor is clinically node negative, and any size if node positive. The tumors must be hormone receptor, ER or PR positive, and HER2 positive by ASCO-CAP guidelines. And the left ventricular ejection fraction needed to be over 50%, and patients needed to have adequate organ function. The endpoint, the primary endpoint, is pathologic complete response in the breast and the lymph nodes. Secondary endpoints included pathologic complete response in the breast, clinical complete response, toxicity, and there are long-term outcomes with recurrence-free interval and overall survivals. Those will be performed when the last patient entered on the study has been followed for 5 years, which we estimate will happen about 8 years after the onset of the trial, which happens to be 5 years from now. Our statistical design assumed a pathologic complete response of 45% in the control arm, not treated with estrogen deprivation. And between January of 2014 and February of this year, 2016, 315 patients were randomized to provide an 80% power to detect 33% improvement in PAS CR from 45% to 60% with the addition of estrogen deprivation. These are patient characteristics summarized in this slide, and they were balanced between the 2 treatment groups. Please note that just under half of our patients were under age 50, 79% were Caucasian, 12% African American, and 26% of our patients had T3 or T4 lesions, and 57% had node positive disease, so this was a high-risk population. To date, NSABP enrolled the largest prospective cohort treated with TCHP. And as you can note here, TCHP has considerable GI toxicity like diarrhea, nausea, vomiting, and dehydration. However, there was no difference in toxicity between the two study arms. The same is true for other toxicities listed here. Anemia and hypokalemia were quite common as well. Febrile neutropenia occurred in about 6% in the control arm and 8% in the estrogen deprivation arm. The overall rate of toxicity was quite high, with over 60% of grade 3 and 4 toxicities. However, it was not different between the two study arms. So now to the efficacy results. NSABP B-52 showed a pathologic complete response in the overall study population of 41% in the control arm and 46% in the experimental arm. This numeric increase was not statistically significant, with a p-value of 0.39. Subgroup analysis by menopausal status showed the pass CR rate to be 44 versus 46% in premenopausal women, 38 versus 45% in postmenopausal women. The p-values were non-significant at 0.80 and 0.33. This is the pass CR in the breast, and again, it's 44 versus 47% in the overall study population, 48 versus 49 in premenopausal women, and 40 versus 45 in postmenopausal women. All those rates were not statistically significant, as you could surmise. So, in conclusion, the addition of estrogen deprivation to neoadjuvant chemotherapy was not antagonistic. We did not see a detrimental effect on pathologic complete response. It did not increase toxicity. Although the regimen was toxic, estrogen deprivation did not add to that. The combination did increase the pathologic complete response numerically, but this was not statistically significant. We plan to do extensive correlative science studies, evaluation of residual cancer burden, RCB, for a more thorough evaluation of pathologic response, as well as long-term outcomes to try and determine if there is a role for estrogen deprivation concurrently with other treatments of HER2-positive breast cancer. And our final conclusion that given the toxicity of standard chemotherapy observed on this trial, findings from NSABP B-52 argue quite strongly for a tailored de-escalation approach where toxic treatments are omitted or replaced with less toxic ones without compromising outcomes. And in conclusion, I would like to acknowledge the patients and their families who participated, my co-authors, co-investigators, the NSABP operations and staff, collaborators from my institution, Baylor College of Medicine. Our funding sources were the NCI and Genentech, and thank you all for your attention.
As we move on to the questions, a reminder that if you're joining us over the phone, please press *1 on your telephone keypad to ask a question. Again, if you're in the room, just please line up behind the microphone right in the middle. And we'd like to ask for Dr. Arteaga to ask the first question.
Mo, you have reported previously of studies that without chemotherapy, double anti-HER2 therapy with anti-estrogens may be a good strategy. Do you think in this case the fact that you had chemotherapy on board, did that become the equalizer and negated the ability to see an effect, may have negated the effect to see an effect of the anti-estrogen therapy?
Thank you, Carlos. Yeah, I believe that is a distinct possibility. Chemotherapy and such extensive chemotherapy might have diluted or blunted the effects of estrogen receptor inhibition. This is why we compared to the other previous trials that we did that you mentioned, we believe that if we de-escalate treatment, we could see a higher response to the estrogen receptor. And maybe also some earlier trials, the other study we did showed that maybe longer treatment in those patients could increase the pathologic complete response because those tumors may not be responding as rapidly as other tumors.
Thank you. First question.
Hi, Neil Osterweil with Oncology Practice. Could you please explain a little bit more about the tailored de-escalation approach you mentioned in your conclusions? You toss out some agents. If so, what are you going to throw out? What might you replace them with?
So of course, anything we say here should be prospectively validated in a study, but we noticed here that TCHP, although quite effective, is quite toxic. There's prominent GI toxicity and other toxicities for this regimen, and this is really the largest prospective cohort that showed that. So with that, and in tumors that have multiple targets like ER and HER2, the question becomes, can we decrease, have a less extensive chemotherapy in a future trial, or even eliminate chemotherapy for some selected group of patients and see if we can maintain, a pathologic complete response or some surrogate for outcome, and follow those patients and make sure that the omission of the treatment does not lead to compromised outcomes.
And would you have a subgroup analysis for patients in this trial?
We will, we've done some subgroup analysis. We plan to do more. I think that what's going to be very interesting is the RCB, the residual cancer burden, because we have seen on prior trials that Dr. Artiaga mentioned, the TBCRC 006 and 023, that in addition to a portion of patients that have pathologic complete response, in ER-positive, HER2-positive disease, there's about a third of those patients have residual disease under 1 centimeter, which could maybe be what we call RCB1. And the question is, did that happen on NSABP B-52? We don't know because we don't have the data yet. But if we see that there was a trend towards improved RCB in those subgroups, then that could actually be a rationale for a future study that could omit some of the more toxic treatments and then follow the patients longer on biologic therapy. Sure.
Caroline Helwig, ASCO Post. Can you remind us what some of the other trials of other regimens in this population have shown for PCR rates? Like how do these compare to what you might achieve with another approach?
Yes, so we actually, the way we came to TCHP is from the Trifina trial, and we wanted to select a regimen. The general idea was that estrogen receptor might be causing resistance, and so the thought was, let's pick a regimen that's quite effective and see if we can add on top of it. Remember, those patients are going to get endocrine therapy anyway, so we're not really escalating treatments, we're just moving up the timeline. And so we actually used the pass CR rate for TCHP from Trifina as a benchmark, and it was actually we assumed a 45%, and we achieved almost that. So this is consistent with what was reported earlier. Other regimens that contain anthracyclines had a numerically slightly lower pass CR rate than this TCHP, but overall this is consistent with prior trials.
Thanks.
Sure.
Hi, Ed Sussman with MedPage today. What were the dropout rates in the trial? You had high toxicity. I assume not
Yes.
everyone finished the study.
So actually, thank you for this question. It's an important one, and I had to take this slide out. It's going to be in the presentation downstairs. We had actually, despite this remarkable toxicity, 90% of the patients in both treatment arms received at least 5 cycles of all 4 drugs, TCHP. And the delivery of the endocrine therapy was also about 90%. So it was really quite high delivery of the agents.
And Dr. Artiaga, can you sort of put this study into perspective? What does it mean for the clinicians?
What does it mean for the clinicians?
Yeah.
Well, we need to do a lot more research, and this provides an opportunity for de-escalation. A point I want to make that is very important that I'm not sure all patients know is that in ER-positive disease, which is this cohort, pathologic complete response does not have the same prognostic and predictive implication as in triple-negative breast cancer. Because as Dr. Rimawi says, these patients are going to have hormonal therapy for 5 years at least anyway, later on. So this is very important. So the fact that there was not a difference in pathologic complete response does not necessarily mean that those patients are going to do poorly necessarily. Did I capture it right?
Absolutely, yes.
Okay.
And the message the signal we wanted to catch from the increased path CR was that there was increased efficacy, but not, I completely agree, not that there is improved outcome. That it's not, the patients who don't achieve pass CR are not necessarily going to do bad if they have ER-positive disease. Actually, the majority of them do quite well.
In this population, we need a different metric a different metric that is not PAT-CR, that measures the impact of that therapy early. It's not PAT-CR, we don't think. We need to find something else. You mentioned residual cancer burden. There are other things like PEPI score. We need other metrics that are more objective and more correlated with long-term outcome. PAT-CR is not. In ER positive.
Completely agree.
Okay, thank you.
Thank you, Dr. Rimawi.
Thank you.